Good morning, almost afternoon, everyone. Thank you so much for making the time to be here today. Really exciting session. I do want to just make a quick announcement, and I'll try to hit this at the end of this intro as well for anyone else that comes in. Our Q&A after the session, we're not going to be doing that via the app. It'll only be done at this microphone here. So if there's any questions that you have post the session, please step up to the microphone and feel free to ask any questions you may have. My name is Jay Anders. I'm the Vice President of CT at GE HealthCare, and I'm extremely honored to introduce a true pioneer in the field of non-invasive cardiovascular imaging, Dr. James J. Thompson. Dr. Thompson is a nationally recognized expert in cardiac MRI and coronary CT angiography, with a career dedicated to advancing early, accurate, and cost-effective cardiac diagnostics. He currently serves as the Director of Adult Congenital Heart Disease Imaging at Johns Hopkins All Children's Hospital, where he integrates cutting-edge imaging techniques to improve outcomes for complex cardiac patients. He has led the development of advanced cardiac imaging programs at the Bay Pines VA healthcare system, where he also mentors radiology residents and collaborates with cardiologists and cardiothoracic surgeons in weekly multidisciplinary roundtables. His work has helped shape the VA's approach to cardiovascular care, particularly in the use of CCTA as a first-line diagnostic tool for chest pain, in line with Class 1A guidelines. Dr. Thompson is Level 3 certified in cardiovascular MRI, holds advanced certifications in cardiac CT, and has been recognized by the American Board of Radiology and the American College of Radiology for his focused practice in cardiac imaging. He also serves as a consultant and educator for Simon Med Imaging and the Veterans Health Administration's National Teleradiology Program, helping to standardize and elevate cardiac imaging protocols across more than 125 VA sites nationwide. His research and presentations span major cardiovascular societies, including SCMR, SCCT, the North American Society for Cardiovascular Imaging, and the American College of Cardiology, with a focus on tissue characterization, congenital anomalies, and multimodality imaging. Please join me in welcoming a leader in cardiac diagnostics and imaging innovation, Dr. James J. Thompson.
Thank you very much. Thank you, everyone, and welcome. It's a very exciting time. SCCT, 20 years in the making, and I wanted to thank the SCCT itself, the administration, including Joanne Olson, for setting these programs together for everyone, and welcome. So what I'm going to be talking about today is cardiac CTA. And what I'd like to do is sort of bring in or encompass the full scope of cardiovascular CT, where it's been and where we're going. There are fundamental past innovations that now help and pave the way for the future. So what are we dealing with here? And I think it's a very poignant topic to bring up, is the scope of the work we're looking to do with cardiac CTA. Cardiac disease itself is, or continues to be, the #1 killer of humans. Sudden coronary death rates have seen no real improvement in decades, and it remains the #1 public health epidemic. So the scope is wide, and there's a lot of area for impact and progress. And I think if we take a look at a couple of examples and put faces to the disease itself, it becomes apparent that it really touches everyone. It accounts for 1 in every 4 deaths. And if we look at low-risk patients, or what we consider low-risk patients, upwards of 70% of patients are considered low risk at the time of their first heart attack. This is an example of Bob Harper. For anybody that knows, this is a celebrity trainer, somebody who dedicates his life to health and fitness and was actually the host on the national program, The Biggest Loser. And he died and was resuscitated while working out at the gym. We also know cardiovascular disease to be a silent killer, and including the first symptom in more than 50% of patients is heart attack and death. This is an example of somebody with means and prestige. This is the CEO of United Airlines, and suffered a sudden heart attack 1 month after starting as the CEO and had to have a heart transplant. We look at what we're able to do with current modalities and the sensitivity. And here we know that 75% of lesions that cause heart attacks are not detected by stress tests and angiograms. This is an example of Tim Russert, somebody from Meet the Press, and he died 6 weeks after a normal stress test of sudden coronary death. Also, coronary artery disease starts early and progresses through your lifespan. And the young are affected as well. The average age of sudden coronary death is 50 years old. And here's an example of a celebrity chef who died in his sleep of coronary artery disease at 44 years old. Other examples, this is Jim Fixx at the top right. He's considered the father of jogging. Again, health conscious, very aware of lifestyle options. He died while jogging at 52 years old. And even our own inside HealthCare, with knowledge of disease processes. Here's an example of a celebrity OBGYN doctor, Jay Goldberg, who died while hiking. If you notice, a lot of these are active people and young males. So up to 90% of heart attacks are preventable with early detection and treatment of atherosclerotic disease. Cardiovascular disease is growing. Cardiovascular disease is the leading cause of healthcare costs worldwide, and research is projecting that over 23 million deaths by 2030. And CT imaging itself is growing, and the procedures grow, and the average number of computed tomography examinations, or cardiac CTs, is expected to increase 175%, and highlights the value of adopting a CTA first approach in imaging and diagnosis. From 2023 to 2024, the average number of cardiac CTs procedures performed per site is expected to increase 8%. And with that, we get increased patient throughput and challenges in patient imaging. The top challenges for cardiac exams as you are imaging the heart while it's beating are arrhythmias, tachycardia, difficulty with obese patients, comorbidities, limited mobility and tolerance of examinations, as well as underlying diseases like diabetes and renal disease. So let's take a look at coronary artery disease and our evaluation of it through this timeline. If we look at 1980 to 2020, we're talking about a generation, more than a generation of time for how we look at and treat coronary artery disease. In the earlier days, we look at a lesion-focused disease process and intervention, including coronary artery stenting and treatment of those lesions with intervention. We also moved on to myocardial ischemia as a focus of detection and treatment, and into looking at the vulnerable plaque and the vulnerable patient. As well, we started understanding more of the concept of the underlying disease process and vulnerable or high-risk type plaques, and including the inflammation that accompanies or precedes these disease processes and lesions. And then we started to understand lesion-specific FFR-driven treatments, again at the lesion level, and moved into looking at clinical and subclinical atherosclerotic disease burden as the main determinant of adverse outcomes, becoming more of a patient-centered look, and understanding the prothrombotic milieu atheroma burden and disease activity as a triangle of this disease process, and getting into or moving from early lesion focused in treatment and revascularization to early detection and prevention. And I wanted to even take a look at that idea because it's a big shift, us moving from treatment to prevention as how we look at coronary artery disease. So it was kind of interesting to me as I got on the plane for the conference, and I thought I'd take an internet search and look at the concept in other areas, including industry and the airlines. So if I did a search for whether it's optimal to take a preventative approach to disease or industry, even with airplanes, it became very obvious that the internet and AI-driven searches quickly told me that it's obviously better to prioritize preventative maintenance over waiting for something to break and increasing the expected lifespan of the equipment and systems. There's many advantages to taking this type of approach, including cost savings, because preventative maintenance requires an initial investment. The cost of repairs after a breakdown is often significantly higher. Reduced downtime. Breakdowns can lead to unexpected downtime, which can be disruptive and costly, especially in business operations, and regular maintenance minimizes the risk of such disruptions. It increases the expected lifespan. Preventative maintenance helps identify and address minor issues before they become major problems, extending the life of the system, as well as safety, because neglecting maintenance can create safety hazards. And the other approach is to run to failure on these systems. And again, the results came back that these would be better utilized in low-cost, easily replaceable items with low replacement costs, and it might be more economical to simply replace them than to invest in the preventative maintenance. So there's clear benefits for early detection in medicine and patient treatments, including the applications of early medical management that we know works and increases lifespan. So what we were thinking of doing is taking a little trip here around some of the cardiac trends that we've seen over the years and some of the historical CT patient challenges that are out there and the need for the latest CT technology. And what I'd like to sort of call this is the detector carousel of progress. And what we're going to take a look at is the CT machine as it envelops and wraps us into the future. So if we look at cardiac trends, we see the most obvious trend. And that's guidelines. So in 2021, the ACC/AHA chest pain guidelines took many new directions. They changed the definition of coronary artery disease. So atypical chest pain is out, and we're now focusing on cardiac, possibly cardiac, and non-cardiac, and how symptoms matter in evaluating patients. We also took a look at structured risk assessments and decision pathways. We would like to incorporate more shared decision-making, and again, an emphasis on risk assessment, emphasis on preventative therapies and guideline-directed early medical therapy. There is a movement for deferred or no testing in low-risk patients, and an understanding to increase our look beyond just luminal stenosis at high-risk plaque, at myocardial microvasculature, and as well including incorporation of multimodality imaging, CCTA and CMR early with a CTA first approach, and selection of an anatomic versus stress testing approach, bringing in the pre-test likelihood of obstructive CAD and addition of calcium scoring. And whether the clinical question is evaluation of plaque or ischemia. So the guidelines give us recommendations of what tests or multimodalities for patient assessments. And if we look at the recommendations in the green, that shows a clear benefit to patient evaluation and diagnosis. And as we move down, you get into more red, and that basically you should probably be doing the opposite of what you're currently doing. And then we also have the level of evidence. So CCTA gets a level A, which is very robust multi-center randomized controlled studies, all the way down to white, which is where most of medicine usually is, in expert opinion. So CCTA is the only Class 1A, Level A test with no previous coronary artery disease. But it's interesting if you look at all of the pictorial representations in the flow chart, you can see, even though we have coronary CTA as a first-line approach, we don't see it really anywhere on the decision tree. If I look at this, I see nice stress, probably a stress EKG. I see some nuclear imaging, getting 2 frames of 4, almost half. We have an echo, who didn't even really want to sign into the indications this year, or what looks like probably an MRI in there. So CTA didn't quite get it showing in the pictograph, but it is the only Class 1A test, and that's why we see that including it in our imaging and diagnosis is important going forward. So what are the trends that we're seeing? And I think they're pretty obvious as well. If we look both in Europe and in the US, we see significant curve upticks in cardiac CTA. We also see upticks in cardiac MRI and PET imaging. And we're starting to see either shallowing out or decreasing trends in MPI, nuclear SPECT, and echo. And if we look at the utilization rates in Medicare patients and Medicare beneficiaries, we see that same trend. Steep curves in coronary CTA utilization, increased curves in cardiac MRI, and down at the bottom, in-office PET imaging, where the others, transthoracic echo, stress echo, are shallowing out. Also, we can see if we take a look at some of the other developments or trends that are going on, we see significant trends, and you can see it at the conference here, in AI, or advanced applications and post-processing to CTA data. If we see here, we see the number of publications by field significantly increasing, and also the number of AI patent filings increasing significantly. And most importantly, we see private investment in AI significantly increasing. And I think we all know the adage, follow the money, but there's a lot of interest and a lot of resources going into artificial intelligence. So there's a lot of noise out there and a lot of trends coming. Very colorful, but I think it's something to understand of how it all fits together and fits into our imaging. And we can see as of January 2023, this is back in 2023, that more than 520 FDA-cleared AI algorithms were available in the United States. Radiology, in particular, took the lion's share of that, almost 400. And if you add in cardiology and radiology together, I think we're pretty much getting to the whole thing here. So where are we going with this? Well, the FDA, I think, made a clear signal that we're moving forward with AI. And as of January 2025, the FDA now cleared more than 1,000 clinical AI algorithms for direct patient care in the United States. Again, radiology, 758, making up 76% of the clinical AI in the United States, with cardiology quickly behind, or far behind, but number 2 at 161. And you can see what comes in third, a very far behind third, with neurology, with 35 algorithms. And just for context, the first AI algorithm was way back in 1996, but there's been a significant increase in the amount of AI filings and grants within the recent past. And although reimbursement for AI in radiology is lagging behind some of this, the potential for payments has already shown its signs. And in October, the CMS updated its payments policies related to the AI-enabled platforms with CCTA, approving both FFR, and plaque characterization. So those are the trends that we're seeing out there. How about the imaging itself? What are we dealing with? What kind of imaging can we get to help move this progress along and position the imaging CCTA into a first-line approach? And if we look at patient challenges, they're significant. The patient population we're imaging is broad. Again, the #1 public health epidemic, chest pain. So these are not only broad scope populations, but they're also aging populations with comorbidities. And with comorbidities in aging population, you have increased difficulties with breathing, with heart rates, with patient tolerance, and with imaging results. Again, if we bring CCTA in, what does the science tell us? And I think if we look at it, what we see and why the trends are here and why it's Class 1 indication is because of the rich science and the rich data behind it. So if we look at the top left confirm registry and see the hazard ratios that are there, we see that putting CCTA as a frontline test is much improved as an individualized risk factor compared to population-based risk factors that we've had before, including Framingham and others. So now we get into looking at CCTA as individualized risk and true assessment of whether a patient has disease or does not have disease. And if we look at some of the other plaque characterization studies that are out there, we clearly see that high-risk plaque is an independent risk factor for acute coronary disease and syndrome. CTA plaque characterization and progression is an independent predictor of acute coronary syndromes. And if we look to the right, we see that increasing number of vessels involved worsens outcomes, and that again, starting statins or early medical management is a significant improvement in patient outcomes. So it's impressive that CCTA has been around so long, and it kind of brings into or kind of envelops what's going on here at SCCT in their 20-year anniversary. And it seems like, if we look back to some of those times, 2005, how important CT was even back then. So if you looked at CT imaging all the way back to 2005 and some of the studies, the negative predictive value back then was almost 100%. 96 to 99% negative predictive value, meaning if a test is normal, it's normal. That's a very powerful result. And this is why, moving forward, we have to understand and still implement patient selection and optimization for the test to show and continue its true power. So if we look at CCTA and some of the reporting or some of the results that it can give, I just showed the negative predictive value and how powerful that can be, but how about as disease progresses along? How about including that high-risk plaque, that mixed plaque, non-calcified plaque? And if we put it into the reporting so nicely by Dr. Curry, who spearheaded CAD-RAD system, and we look at the CAD-RADS results and the warranty period that we get with cardiac CTA and a normal test. So if a test is normal, there's a very strong warranty period for that test. Again, if it's normal, it's normal. As you get increase in the disease and increase in plaque complexity, you get increased hazard ratios. But what we're not seeing here, or if you look at the very bottom of the CAD-RADS, there's something called the CAD-RADS-N. So this puts you into a position that sometimes the cardiac CT exam is not diagnostic, or you don't really know whether the patient is normal or abnormal. And CAD-RADS-N is not just vessel and segment specific. If there's a segment that is not able to be diagnostically reported, the patient or the examination is CAD-RADS-N. So then the test has to go back to another evaluation, another type of test, a stress test. So if a vessel has motion or non-optimized with contrast within the lumen and you can't see fully through it, then the power of the test gets shifted, where that negative predictive value and the lesion characterization becomes difficult. We'll come back to the RCA motion a little later. But this is where we see difficulties in plaque and patients and the examination itself. So as calcium increases, so does the decreasing power of the test's accuracy. So the ability for the test to be reproducible and be in line with high-level agreement between readers and rereading, calcium obscures the vessel lumen. And the increase in the amount of plaque or calcification and the decrease in the size of the vessel go together that become non-evaluable. And you can see quickly that that power of coronary CTA, if you look at the two at the top, the negative predictive value and the sensitivity. Sensitivity meaning a low false negative result. That very quickly as the bulky calcified plaque increases, so does the accuracy, the specificity, and the positive predictive value. And if we see this, it's not just in calcification as well, it's also inclusive in motion. And these are inherent challenges in the physics of the CT machine. So as you get smaller size vessel and increase in the bulky calcified plaque, you can not discern the vessel lumen well. And motion as well. So as motion increases and vessel size decreases, similarly, you get difficulties with accuracy. And if we take a look at the natural history of coronary plaque, phenotypes, and high-risk type plaque, we see an increasing disease process that increases with calcified and bulky calcified plaque as someone ages and disease progresses. In the Scottish heart trial, the Scott Heart trial, showed us that adverse coronary characteristics and overall calcified plaque burden confer this increased risk of MACE or major coronary artery event. So as we age, or as disease progresses, the calcifications increase and bring in those challenges of diagnostic evaluation. However, the importance of plaque characterization is very well understood with high-risk type plaques that we see. So whether it's a stenosis greater than 50%, positive remodeling with predominance of non-calcified plaque, and low Hounsfield unit components of plaque, as well as napkin ring sign, which correlates well with conventional angiography, high-risk lesions, and spotty calcifications within the mixed plaque. And you can see a lot of these have to do with the non-calcified component. So that non-calcified high-risk component plaque confers significant increase in MACE. And plaque characterization is an important concept moving forward as we move into earlier and preventative measures and earlier medical management and treatment. And if we look further, we see that this progression of disease increases with obstructive disease as you age. So very interestingly, you can see that as we age, you naturally increase in your calcified plaque. However, there is an interesting group in this, if you look at those younger patients, that have non-calcified plaque or more non-calcified plaque and obstructive coronary artery disease. And I think that's a very important concept and area moving forward as we move towards a more preventative and earlier diagnostic evaluation of patients. And I think that starts to play out well in the recommendations. So if we look a little deeper into the chest pain guidelines, we clearly see some distinctions coming out, where if we're looking at incorporating coronary CTA or another test, if we look at age, we see that younger patients have a better benefit or favor the use of coronary CTA. And stress testing favors older patients greater than 65. And we can see that in the PROMISE trial, which clearly showed again that CCTA is a test of choice for under 65 and lower calcium scores. Again, that negative predictive value that you saw all the way back to 2005. A normal test is normal. But as we age greater than 65 and higher calcium scores, adding a functional test becomes much more predictive. So what I think we're kind of seeing here is a bimodal distribution of coronary CTA, where almost two subsets in one. So we call it coronary CTA, and as we move forward, we're now performing or setting up programs for coronary CTA. But it's important to understand that there are two distinct subsets here, where there are those more negative predictive value and early preventative side of coronary CTA, where the calcium score is low, a younger patient, female, and that negative predictive value and preventative. Whereas we move into the other category, older patients, established disease, higher calcium scores, and that moderate to high risk patients, we start to get increased challenges as well with those patients. So those are the patients we see have more inherent difficulties with the CT scanning machine, the inherent physics in the machine. And the challenging patients with difficulty breathing, motion, lying still, increased BMI, ectopy, and including established disease with unpressurized systems where you're collateralizing your vessels, and low demand states. So let's move on to the applications of this now. Now that we understand the trends, we're moving to coronary CTA. It's the frontline test. It's in the indications. And we see the difficulties in the different types of patient populations that are out there. Now, what is the technology we're going to use to implement these indications? And I think this is well understood with information itself or the transmission of data that you collect. And I bring up here Claude Shannon in 1948 had a paper and is considered the father of the information age and information theory. And in a mathematical theory of communication paper he published early on, it introduced this concept of the computer bit and established the fundamental limits of data compression and data transmission. So it describes the source images or source data, the transmission and processing of that, which we're getting into more and more, and the utilization of this information within the system, including entropy and information loss. So if we look at the scan that we get, it's not the scan that you see on the view box, which is the PACS system nowadays. The original information that's picked up is the input scan, the actual photons that are collected from the transmission of X-rays through the patient and collected on the detectors. And that input scan sinogram is then converted algorithmically into information and bits and pictures. And this is where you can even see in the picture on the left, moving from the original scan to the actual output CT image, we move through a deep neural network and kernel application algorithms to optimize the scan and the images. So are we there yet? That's the picture on the right. If we do too much data manipulation, if we don't understand data manipulation, can we get to where we're going next? Can we get to these applications, these AI programs that we're now moving towards? The answer, of course, is yes, but we all need to be working together and understanding how it moves through the system. So if we want to do quantitative coronary plaque analysis, if we want to do FFR data post-processing, if we want to go in the future with perfusion imaging, if we want to go into inflammation, pericoronary inflammation of the vessel, how detailed and what information are we using? So model calculations have an inherent understanding, a human understanding, right? And this is Latin, quod non habet, non potestere paradigm. And I think it's easily understood to most logic physicians that if you don't have the information or you didn't collect the information well enough, you cannot continue with that information. Cad rad zen. If the information just doesn't come out, you cannot move on from it. And sometimes it's a little bit easier understood as the old garbage in, garbage out. If you do not have the information, even if you have a perfect model for quantifying the information, it doesn't translate. And this is the idea of all of us together, help us help you. Let's get together to get the correct or best optimized imaging and patient selection to get the best correct answers for downstream. So what are we looking at a CT machine? Is it too difficult to understand? Is it something maybe just the physicists deal with and just give us the pictures? Or is it something that we can all incorporate into? And if you look at a CT machine, and even some of the reasons it's expanding or going through exponential growth is because it's simply an X-ray machine hooked up to a computer. And if you look at the microprocessor advancements that have occurred and Moore's law understanding of exponential growth of that we can see why all of these advancements or significant improvements have happened so quickly. However, as we know from physics itself, is sometimes you can't get past the fundamental physics and the fundamental laws. It's a machine that's emitting or dealing with photons and radiation. So you're dealing with the difficulty or persistent limitations just of a X-ray machine. And if a patient is breathing, arrhythmias, decreased pliability of the vessels, meaning more motion, the increase in bulky calcified plaque, and bulky calcifications and decreasing vessel size, these inherent physics become challenges. And including moderate stenoses, which has always been a difficulty with cardiac or coronary CTA, of being able to accurately identify what falls into either a mild and non-significant stenosis or a severe and significant stenosis. So I think in any system, and in particular advanced cardiovascular CT and high spatial resolution and high temporal resolution imaging, the outcome is easily understood as only as quality as that input. And we can't expect post-processing and AI-driven clarity from cluttered, obtained source data. And this is why we look to leadership and companies and industry and GE to optimize the acquisition foundations, to not just feed the downstream algorithms and applications and innovations we're going through, but to fuel all our subsequent and important result of diagnostic precision. So we're moving on to some of the GE equipment, and this is the lineup we have. So if you look at the GE portfolio, we have on the left the Revolution Maxima, and all the scanners are beautiful. The Maxima is reliable CT design to maximize every step in the CT workflow from referral to report. The Ascend platform, a revolution in CT efficiency. So we're all getting into the actual processing and throughput and patient tolerance of the exam. The Revolution Vibe, a new version for every heartbeat, and the Apex platform, outstanding image quality for every patient. And really the understanding is this, is the CT machines are very helpful and important in getting quality images. So if the patients are more comfortable, easier to scan by the technologists, easily upgraded, so as you move on in your CT practice, you're able to upgrade to higher and higher level equipment that can scan more and more difficult patients and more easily. Some of the things you'll see here that have changed over time is the machines now have the EKG tracing or screens, patient and technologist facing, so you can easily see how a patient is trending EKG-wise and how they're tolerating the prep and potential for exam. They're also quieter. If you scan a patient, you can hardly hear the detector rotating around. The EKG leads are now on the table. The table can be feet first. So all of these things increase the optimization for the patient imaging. So if we look at a timeline too, it's very helpful to see, and this is the idea of past predicts future. And here we go again, kind of mirroring that timeline, right, of SCCT itself, 20 years. Those potential powerful studies of negative predictive value, 2005. So here's some of the first scanners. The Lightspeed VCT was the first 5-beat cardiac CT scanner. And a lot of these innovations are very important, and we have to have industry that supports this investment. In 2007, we changed to a step and shoot, which started to bring in more of the volume scanning to decrease the radiation dose. So before that, we were doing helical scans, which you can still do now. But helical scans have the detector and the X-ray machine on the whole time, so they're inherently higher radiation doses. And always the biggest decrease in radiation is non-scanning of an area. So if you do a volume scan of just the area of interest and just the cardiac cycle phase you're looking for, this all significantly increases radiation dose. And now it's optimized more and more for us. Before, back in 2005, you would have to be very involved in that scanner. It could be done, but you had to be very involved to get those images optimized. Whereas now, roll forward to 2025 with the Vibe, you put the scanner on, you put the patient in, it sets up the prep, it sets up the scanner, the protocol, and all you really have to do is still stick in the IV and put on the EKG leads, and sometimes not even that. But this all just increases your success in doing cardiac CT imaging. And I'd like to point out too, it's not just the coronary and negative predictive value we're talking about, but a lot of the power of CT comes in its structural information. And even though we're getting more and more volume scan information in one cardiac cycle, it is back in 2004 when we moved to the 64 slice scanners and those detectors became isovolumetric, meaning you got the same resolution in the X, Y, and Z axis. And that data you could then take and do very highly accurate and highly diagnostic structural work. So you can see on the left, we now have that increase in the detector volume. 160 millimeter whole heart coverage, as opposed to if your detector's smaller, you can't quite get the whole heart in one shot. You're going to have to make a couple of rotations, which increases the possibility of irregular heart rates or irregular breathing, and the benefit of being able to scan in one shot the whole heart. Consistent image quality and streamlined workflow, even in difficult patients. And you can see the rotation time is all the way down to 0.23 seconds. That's the industry's fastest rotation with automated whole heart and motion correction. Those effortless workflows with one-step decision tree to use for less experienced staff and technologists as you increase and grow your cardiac program, as well as what we mentioned from the source data, true fidelity, which is an application or a kernel before or just after the source data acquisition. And it delivers outstanding cardiac images with clarity and improves that visual sharpness even at low doses, powered by the deep learning algorithms. And we can even perform ECG-less imaging on patients without an ECG trace. Powerful cardiac technology bringing clarity to all cardiac cases through motion management. So we see the Revolution Apex platform and the Revolution Vibe features that industry's fastest gantry rotation, 0.23 seconds, an effective temporal resolution of 19.5 milliseconds. With the Snapshot Freeze 2, which images with motion-free imaging. And that brings me back to the RCA I showed you earlier with a CAD-RAD-XEN, that if you scan that patient and you see motion, not just in the whole vessel, but even just segmental, you still don't know whether that patient has severe disease or not, CAD-RAD-XEN. However, Snapshot Freeze 2 allows you more options, again, empowering your imaging to get diagnostic images. The true fidelity shows that detail very well, and you can see here, especially the top image, you see that napkin ring sign, which again is a high-risk plaque, very well correlated with conventional angiography high-risk plaque. You see that thin calcified density periphery surrounding a lower attenuation component. And that high-risk plaque is much clearer with the implementation of scanner-level algorithms from source data. And the optimization for the workflow is improved. You can see here with one beat technology or one rotation of the scanner, acquiring the whole heart in one shot allows you or frees you from so much interaction with the scanner and the protocol optimization. So you have one decision tree for the technologist and one decision tree for the imaging, as opposed to previously where you would have to have multiple workflow and protocol for the acquisition. And this not only allows more improved workflow with the technologist, but allows you to free yourself also from the leveled technologists. You can increase more technologists into the day-to-day scanning, and also reduces unwanted difficulties and medical errors. So if you get a scan that you can interpret diagnostically more often, it's significant to the patients, your patients, and to the system that you're in, hospital system or outpatient. Again, you can image if needed without ECG tracing. So the addition of this tool is useful where excluding the ECG connection and streamline patient prep, including skin prep and connections. The scanner can evaluate the ECG lead and scan during optimal ECG or cardiac cycle. Again, that large volume scan, Z-axis coverage, 160 millimeters, significant temporal resolution with 0.23 second rotation, and the optimized throughput of smart phase, looking at the cardiac cycle and optimizing the best cardiac phase or more motionless, and snapshot freeze motion correction. That one beat cardiac gives a comprehensive tool for all the diagnostic applications with exceptional detail and quality. Can image patients with plaque at low doses, patients with significant BMI and morbid obesity, as well as atrial fibrillation with diagnostic images, and mixed plaque with calcified and high-risk plaque, being able to fully detail the characteristics and the plaque burden. Patients with mixed plaque and high heart rates, 90 beats per minute in the top category, and high calcium scores at low dose, as well as patients with stents and bypass grafting. So let's look at a couple of cases. And here we have a 64-year-old male with a BMI of 30 and high irregular rhythm and arrhythmia. Scan was performed without cardiac beta blockers and utilizing that one beat acquisition with rotation time 0.23. Reconstructed with the true fidelity kernel with snapshot freeze. And the patient's heart rate varied between 82 and 130. And despite these challenges, you can see the scanner in the purple dash line evaluating the EKG lead and triggering during that optimal end diastole and motion-free phase. Here we have the Vibe with the CTA heart rate varying between 33 and 105, and you can see the quality of images and the diagnostic images that are available. This is again with the high volume detector, fast rotation time, and KV of 100 and MA of 560. And that came to a DLP of 453 with this level quality images. And you can see those curved planar images of the vessels are not only diagnostic, they're very, very clear and clean. Here we have an example of the ability of the scanner to re-trigger if necessary. So this is a highly irregular heart rate between 52 and 117, ectopy, pretty much all over the place. And during the first triggering, you can see on the right, 73% of the phase, there's too much motion, again, CAD-RAD-XEN. You just don't know or don't visualize that segment of the vessel. However, the scanner picks up the increase in irregular rhythm or ectopy and re-triggers. Something you would have to do on your own without that type of scanner. So often I'll get called for possibly re-injecting a patient, or do we need to rescan? In these cases, it significantly reduces or improves your time being able to stay where your mind should be and reading the examinations, rather than evaluating if it's necessary for another re-injection. However, that's what this does, re-injects, scans again, and you can see from the middle and the end right MIP phase that the full length of the vessel is imaged and evaluable. Bypass grafting with the volume scan. Again, you can see axial gated, 2 volumes in this case, including all of the lima and rima takeoff from the subclavians all the way through touchdowns, including stents in the distal native vessels. Here we have a 1-beat CCTA in a pediatric patient. So again, the importance of being able to acquire the whole heart in one rotation, particularly in high-level structural exams like congenital disease and adult congenital disease, where the normal anatomy is significantly challenged and optimization of the test can be difficult, both contrast timing and scan volume, where in this case, you can scan the entire heart or region of interest in one shot. Again, high resolution, high rotation time, temporal resolution, 70 kV, MA at 1,300, and we get a DLP of 38. And these are the full scope of images or acquisitions that you can get. It's truly a breakthrough. All of these advancements go into being able to acquire a diagnostic image for what we're looking to purpose moving forward with CCTA as a first-line approach. So in renal patients, you can utilize low contrast volumes, 25 milliliters, beautiful images, curved planar. You can do high BMI patients with lower noise, 3.2 millisieverts. Atrial fibrillation with no motion and low dose. And you can see 2.5 millisieverts with a heart rate of 120, and you can clearly see, and this is an example of what we say severe disease, even though calcium scores are high, you can very easily depict whether there's a severe stenosis sometimes. So in that case, you can see the occluded vessel mid to distal segment. Variable heart rates with no motion or low dose, 0.4 millisieverts, and stent follow-up as well, with low noise and high signal with 3.2 millisieverts. And again, the ECG less cardiac optimized or option for, and in some settings, acute chest pain. And then we move on to future. So there is whole heart imaging with the future technology to consider of photon, deep silicon photon counting. And GE HealthCare is taking a unique approach using the deep silicon to help redefine cardiac imaging. It delivers ultra high resolution, spectral imaging, and advanced tissue characterization. Again, one whole heart shot. All the things I mentioned before, negative predictive value, optimization of structural work, and now we can do whole heart with spectral imaging and tissue characterization single scan. That means clearer images of the coronary arteries, better plaque analysis, safer exams for the patients. And it's not just an evolution, it's a transformation in how we're going to treat and diagnose heart disease. Photon counting doesn't show us the anatomy, which CT is extremely powerful for. It also shows us or can optimize the energy. So if we're dealing with photons and the energy of X-rays, it comes in the form of Bremsstrahlung energy, which is a spectrum of radiation, low to high radiation photons. And you can take advantage of all that information at the detector and scanner and source level. In the end, I think it's not just about better images, it's about better care. Over the years, we've seen some technology advances based on trends and patient struggles, and photon counting is transforming that cardiac imaging into faster, safer, one whole heart into a single, for clinicians and patients, examination. CT as frontline test. And I put a little slide in if you're interested in cardiac CT and this information. We put on a symposium down in Southwest Florida, Tampa Bay. GE will be a sponsor, and we're going to take a look at and just unfold more of those advancements in cardiac CT and MRI, and including the emerging technologies that are becoming available with artificial intelligence. Thank you, everybody.